All right, welcome back. Now we're still talking about depressive disorders, and we've identified what depressive orders are, what possible causative factors. Now we're going to assess our patient. So we're going to meet our patient. We're going to look at the depression scale. The Hamilton Depression Scale is a great tool, and I'm going to walk through this to help you with that tool. So what is the patient's mood? Do they have feelings of guilt? Are they suicidal? Are they having difficulty sleeping? Are they having problems with their work? Are they having slowing in their movements? Are they agitated? Do they have anxiety, which could lead to psychosis? Remember we said that, moderate anxiety, you're starting to get into that severe panic anxiety, you lose touch with reality. It's very frightening. You can have anxiety, somatic disorders come out of that, hypochondria. Are they having weight loss? Are they lacked insight? Things that we talk about when we're doing mental status exams is also part of the assessment. Are they helpless or hopeless? Decrease in activity. That's disturbed sleep. On the behavioral health unit, we talk about, how many hours of sleep did they get, things of that nature, because that's really indicative of how our holistic health. Difficulty making decisions, difficulty in relationships, feeling best in the morning, worse as the day goes on. So we're assessing. So our patient may have mild depression, they're having some affect issues, their feelings. They're having some anger, anxiety, behavioral, they're tearful, they're having aggression, cognition, they're preoccupied with loss. They could have difficulty with lack of appetite and difficulty with sleeping. So that's what mild depression would look like. Moderate depression is when you're really feeling helpless and powerless. You're slowing behaviorally, your cognition is slowed, you're having difficulty with sleeping and eating. Now, severe, because we're talking about major depressive disorder, it's usually when you're in the hospital. You're totally despair, feeling worthlessness, flat affect. You're slowing, lack of attention to grooming and hygiene, difficult with interactions. Your cognition is start to be considerably impaired. You may have suicidal thoughts, and inability to make decisions, and constipation occurs. Holistically, our body doesn't do well when we have all these elevated levels in hormones from stress and anxiety. So we have changes in our GI system also. And then the medications also have problems, can lead to constipation. So we've listed some nursing assessment. Now we're going to develop some plans of care based on is our patient suicidal? Risk for suicide is okay. I know in the medical model, when you're doing your concept maps, you can't use risks. Well, there's two things with suicide: either you're alive or you're dead. So if you already committed suicide, then that's why we call it risk. And it's related to depressed mood, feeling of worthlessness, anger, directed inward, and misinterpretation of reality. So a diagnosis we could have is low self-esteem, learned helplessness, feelings of abandonment by significant others, impaired cognition, negative view of self, powerlessness, and helplessness, hopelessness. We have spiritual distress, social isolation. All of these things are things that we could put our plan of care. Disturbed thought processes, especially if we're really having significant anxiety and we're losing sense of self and losing touch with reality. So now we're going to, how are we going to know if our patient's getting better? Okay, we help them set goals for self. We help them with coping strategies. We help them try to grasp that they have certain things that you have control over. So this is how we will know if our patient is getting better. So what are we going to do? We're going to keep them safe in the hospital. Very, very important. Safety first. That's why everyone on the behavioral health unit, have all sharps removed. They're not allowed to have any ADLs in their belongings. We take away their shoelaces. We take away their belts. I mean, we want to keep them safe. And that's so hard for people when they're sad and overwhelmed. And then we take away a lot of their control. But we have to have a milieu that's safe. And we want to increase their self-esteem. We want them to get some level of control back. We want them to talk about their anger and work on these, in the therapeutic groups that guys are going to be implementing in the on the units. That's what we're working on. Areas of that related to that. And then we're going to teach our patients about grief and loss and what is depression. Why do people get depressed? We don't know, but this is what we think. Okay. Just like you're learning, this is what we do for our patients. We help them. And we talk about our medication, assertive techniques, stress management techniques, ways to increase self-esteem. Electroconvulsive therapy is such a great tool for patients who are majorly depressed and they're not responding to medication. ECT is such a wonderful tool. It has such a negative connotation in our society. It's barbarically portrayed in the media and in Hollywood, but that's not the case. I mean, you're under general anesthesia, and it doesn't help everybody. But if your patient is just so sad and helpless and hopeless, and medications aren't helping, it's a good option. So being positive about these things and supporting them in their decision making. Make sure that they have, when you're developing their plan of care for their wellness toolkit, that they have the numbers for suicide hotlines, self-help groups, legal financial assistance. And then we're going to see if what we're doing helps with this patient. So has the patient harmed themselves while they've been in the hospital? Have they had the suicidal thoughts subsided? And how do we know they're ready to go home? It's such a great question. Are they able to set goals? So are they able to maintain some type of sense of control of their life? And we do that through individual therapy, group therapy, that team approach that we talk about in the psych setting, cognitive therapy, that transcranial magnetic therapy, light therapy, like I said, the ECT, and medications. Okay, we have SSRIs, we have tricyclics, we have MOA inhibitors. There's lots of medications, treatment that we are going to options with our patients. So, it takes 4 to 6 weeks for these medications to be effective, and we need to let them know that. Most of them are in the hospital for, 7-10 days. They're not going to get the full effect. And also it's important to remember too, once they start, say they are majorly depressed, they have major depressive disorder, and this is important to tell the family, is that, once they start to feel better, they have the energy to commit suicide. So that needs to be brought to the attention of the family members, because it's generally a couple of weeks post-treatment that you start to see an increase in that suicidal tendency. They can't drink alcohol. They should avoid smoking. That's really hard. And then risk for antidepressants during pregnancy. I talked to a girl at St. Mary's the other day. She just found out she was pregnant. She's depressed. She's worried about the impact that these medications are going to have on her unborn child. Very realistic things that nurses have to contend with. So we have such an important job when we're teaching our patients about aftercare and discharge planning and medication management. So here's one that the NCLEX loves. I don't know why the boards like to talk about MAOI. So this is a triamine foods that are high in triamine, because when you are taking these medications that are considered, they impact the absorption of triamine. All right, and foods that are high in triamine, wow, there's some red ones there, and that's a moving slide. So I remember aged cheese, tofu, red wine, bacon, pepperoni, liverwurst, these aged meats. Okay, hint hint. Okay, so I look at, when I'm thinking about myself personally, you know, I'm suffering from depression. It's like, am I going to be able to give up coffee? Am I going to be able to not eat yeast products like breads? That would be something I'd have to say to the nurse and the doctor. I'm like, this is not the medication for me. So that's an important part of what we do in with medication education, because you know, you have to avoid these or you go into a crisis. It's a malignant hyperthermia. You know, your temperature will go skyrocket. I've seen patients' temps go up 108. You know, you start to lose brain cells at 106. So, you know, these is a dangerous situation. Hypertensive crisis, hyperthermia, and loss of life can occur if they're non-compliant with these medications and not picking up on these subtle side effects. There's a serotonin syndrome we're going to talk about in our class too. That is from, you know, SSRIs, and we need to be aware of what these symptoms are and teach these to our patients. So that's the last slide. So I'm going to tell you a little story. Let me stop the share. I'm going to talk about a patient that was on the unit that many of you know. Like I said, this is week 2. His name is Joe, and he was on the general side, and when he had major depressive disorder. Okay. And his affect, you know, he was very guarded, I'd like to say. He was almost, he wanted to share, but it was challenging for him because what he was struggling with in his mental health. When Joe came into the hospital, and, you know, we talk about these things because this is how we learn. When Joe came into the hospital, he was overwhelmed at work. He's had problems with anxiety and depression in the past, had gone to the doctor. The medications were not helping him. And he made the choice to come to the hospital and get treatment because he was worried about being around guns in his house. So he's risk for suicide. And so, you know, you can see how helpless and hopeless he was. You know, he's worried about his job. He talked about that frequently. He's worried he was going to lose his job. He's worried about his relationship with his children. And so these are the things that we help our patients with when they are in the behavioral health unit. And we talked about coping strategies. One of his goals for the day is that when I was just there today with Joe, and he said, you know, I want to learn coping strategies so I can manage the stress and anxiety that accompanies my life and is impacting my mental health. So that's powerful stuff that we're doing with our patients. So we talked about coping strategy. We talked about the impact that stress has on our brain. So this is how we help our patients. So just be mindful of that when you're doing your therapeutic groups. This is what it's all about. We're helping them in that recovery process and navigating through a very difficult to treat disorder. And you know, being compassionate for this population is so important. So, all right, so that ends this presentation. So I will continue on. We're going to talk about suicide in the next part of this 3-part presentation.